So hello, good afternoon, everyone. So so we still have a minute before we start our tech talk. So at exactly 2 o'clock, we're going to begin our 11th episode of Tech Talk. Thank you. Hello again, good afternoon. So welcome to our 11th episode of the Dalubhayop Tech Talk. So medyo konti pa tayo, but since it is already 2 o'clock, so we will start our Tech Talk. So to begin with, I would like to lead a prayer, to say a prayer before we start. Okay, so let us place ourselves in the holy presence of God. Almighty God, our Father, we praise and thank you for this day. We come to you asking for your blessing and help as we are gathered together virtually. Please bless our speaker for this day's Tech Talk, that he may be your instrument in order for us to find the passion to excel in our chosen field of practice. We pray for guidance in the matters at hand, and may you bestow your blessings after this activity, so that we may go out and practice what we learn in the spirit of love and enthusiasm. May we realize that this activity should glorify you, your name. We ask this in the name of Jesus Christ, our Lord. Amen. So again, good afternoon, everyone, and welcome to our 11th episode of Dalubhayop Tech Talk. So this day's episode, we're going to talk about anesthesia and pain management. Now, to formally open our activity and to welcome all our participants, may I call on Dr. Orestes Borja. Doc Resty, please.
Okay, good afternoon to everyone. To our distinguished speaker, whom we will be introduced later, fellow veterinarians, students of veterinary medicines from different universities and colleges, friends of Dalubhayop. Isang mapagpalang hapon po sa ating lahat. Good afternoon, everyone. I am Dr. Orestes Borja, graduate of veterinary medicine from La Salle Araneta University, a retired military officer and a member of Dalubhayop. This afternoon, in behalf of Dalubhayop, it is my great pleasure to welcome you to today's session, webinar, or Dalubhayop Tech Talk on Anesthesia and Pain Management. Once more, this is a very interesting or attention-grabbing and timely topic for discussion on anesthesia and pain management. Today's topic will solely boost our skill and knowledge and updates on the latest management about anesthesia and pain management. Thank you for joining us and for spending your precious time with us today. I sincerely hope you will enjoy our topic, and I'm very confident that we will find you understanding insight in today's topics after the webinar. For those of you just joining us, again, welcome. I wish you all a successful session, webinar. Again, thank you for your participation. At this juncture, let me allow me to introduce our association, Dalubhayop. Dalubhayop stands for Samahan ng mga Dalubhasa sa Palagamutang Hayop sa Palawan. Dalubhayop is an association of licensed veterinarian in Palawan and presently based at Puerto Princesa City. It was organized and founded last 1994 with 9 pioneering members headed by late Dr. Jerry Ortega. The goals of the association is to work for the welfare unity, protect the rights and interests of all members and promote the professional development of veterinary profession in the province of Palawan. At present, the association is represented by more or less 25 licensed veterinarians. The Dalubhayop is an affiliate member of Philippine Veterinary Medical Association. Again, good afternoon to everyone.
Thank you very much, Doc Resty. Okay, so before we move on with our presentation, our discussion, first I would like to remind everyone to please mute your microphone to prevent any static or feedback. And if you have question, please you may use the chat box, or if you want to speak up, you may raise your hand. Okay. So again, good afternoon, and I would like to introduce this episode speaker. So, our speaker for today is a graduate of University of the Philippines at Los Baños in Laguna, and he owns with his wife, Dr. Ivy Alvarez Zialcita, the Animal Wellness Veterinary Clinics and Hospital in Cebu. Ladies and gentlemen, I would like to give the floor or the room to Dr. Luis Guillermo Zialcita. Dr. Guillermo, good afternoon. You may now screen. Yes. Hey, good afternoon, Doc.
Good afternoon, Doc.
Good afternoon.
Yes, you may now share your.
Thank you very much for the opportunity to share my passion for anesthesia and analgesia. I hope you are able to learn a few things. If I'm going too fast or my volume is too low, please do let me know. If you have any questions, please also, we'll have time for discussion. Can you see my screen? Is my screen okay?
Yes, Doc.
Okay,
Yes.
so let's talk about anesthetics. During registration, the organizers were kind enough to provide a couple of questions in order for us to have a better idea of how many anesthetic agents, and 45% have 2, 16% have 3 or more, 16% have 5 or more, and 23% of you have 1 anesthetic available. And then, do you routinely give steroids prior to anesthesia? 97% said no, and 3% said yes. Most common NSAIDs you use, which are the ones available in the country, meloxicam is the most popular, tolfenamic acid, carprofen, percoxib, flunixin, and ketoprofen. So good, at least there's a good general consensus. And this is one of the biggest issues we have, I think, for the whole Philippines, the access to opioids. The ratio is not bad, so 39% can or do have access to opioids, and 61% do not. So for today, we will be discussing pre-anesthetic assessment, which is a very big component of the safety factor for anesthesia. Part of which is ASI scoring. And then we'll be going to local blocks. We'll be discussing some of the things that we can use in order to minimize the need for more general anesthetic. So we'll be discussing splash blocks, nerve blocks, intertesticular and regional blocks. Um, we'll also be talking about dental, intravenous regional, and epidural anesthesia. And then finally, we'll be discussing a couple of protocols that I use in our practice. This is our typical setup during anesthesia. We have a monitor, we have a fluid pump, and we're lucky enough to have several doctors on hand at all times. No. Now I have a couple of questions. If you This is live polling, so if you would please go to menti.com and then enter the code 55342944. And there are a couple of questions that are there. So we will go to this question. If you would answer this, just one word, and then whatever first word comes to mind. Yeah, we're getting answers. Very good. Thank you. Keep them coming. So, what is the first word that comes to mind when you hear the word anesthesia? Don't be shy. The more we get, the better our understanding will be.
Relieve pain.
Yes, relieve pain. It's a good one. Okay, painless, deep sleep, all of which are very good um, synonyms to anesthesia. Next, what challenges do you face with regards to anesthesia? So just go to menti.com and then you can answer through there. Or if you'd like to type in the chat, we can also do that. Or maybe a challenge availability. Yes. Availability, risks, side effects. Yes. All right. Anybody else? Okay, one last question.
Lack of
Yes, Doc.
skills.
Yes, lack of skills. We can do something about that. We can learn do that. Late response upon addition of anesthetics. Yeah, great. Adverse effects. Yes. All of these great input. Very nice. Okay. One more question, if I can get it to move. Okay. What anesthetics have you used in your practice? So injectable anesthesia, local anesthesia. You can put up to 3 answers per person. Inhalant anesthesia. Fourth is propofol. Fifth is our favorite and sometimes only option, tiletamine and zolazepam. So we'll just give it a little time for the answers to start coming in. Well, there we go. Okay. Hmm. Very good. That's not the answers I was expecting, and that's great. Okay. Thank you for your answer. Thank you for participating. We'll go back to my presentation. So this is a case that we did where it was a diaphragmatic hernia, wherein there are two anesthetists, myself and one of my doctors, and there is a team. There were actually 3 surgeons. And the surgeon does not have the difficult part in this situation. The difficult part is the anesthetist, because we're breathing for the patient and we are making sure that the depth of anesthesia is not too much because of the collapsed lungs. So this is one of the more challenging anesthetic cases that we see. So general tips and tricks in order to get more comfortable with what we're going to be discussing is to go slowly the first few 100 times. Practice, practice, practice. No? And then aspirate. Whenever you're giving a local anesthetic, you want to make sure that you are not in the bloodstream. Now, you're not inside a vein, you're not inside a artery, because it can have other side effects which we don't want. So anesthetics, what are anesthetics? Anesthetics, they relieve both the states of, or they may provide a state of unconsciousness and a state of inability to feel pain. No, that's the 2 main goals of anesthetics. They should have a wide safety margin and be tailored for each individual. So not all anesthetic protocols should be used all the time. You should tailor to your anesthesia to what your patient needs. And one of the most useful tools will be what we will be discussing next. In our practice, depending on the age of animal, there's always a full physical exam, usually a week before the procedure, and blood tests, which are valid for 1 week. If the dog is a young, healthy animal, we only require a CBC, a complete blood count. And if the dog is a senior dog or has other prior diseases, then we usually require a full blood chem test. So blood chemistry as well as a CBC. Sometimes we require radiographs in order for us to make a full assessment of what the risks of the anesthesia will be. And the biggest tool we have for this is the American Society of Anesthesiologists scoring method. What we've done is whenever we prepare a patient or the patient arrives and has been given an IV line and fluids, before we proceed into the operating theater, we discuss, so the surgeon and the anesthetist discuss what ASA score, if there are any outstanding conditions that we should be aware of, and what we can expect. So ASA scoring is from 1 to 5. 1 is a healthy pet, usually for elective, spay or neuter procedures. 2 will be mild systemic disease, so an older dog that has to undergo a late spay or a neuter, or sometimes dental. Mild anemia, which we can see a lot, especially if they've had Ehrlichia in the past. Anemia or obesity. ASA score 3 is moderate systemic disease, so fully controlled diabetes, cardiac problems. ASA 4 is severe systemic disease, so concurrent Ehrlichia infection is one of them, bleeding from the abdomen. And 5 is usually those dogs that if you do not go into surgery, they're going to die anyway. And this is something that you have to get into practice and discuss before going into the operating theater. It also helps colleagues define what the risks are before surgery. So patients with a score of 3 or greater are 4 times as likely to get complications than those from ASA score 1 or 2. So automatically, when you see that the dog has an ASA score of 3, you're already having complication discussions with the owner. So you need to discuss that, okay, since your dog already has a pre-existing condition, the chances of something going wrong around surgery and around anesthetics is 4 times greater than a healthy dog. Automatically from that beginning, you're already discussing what can go wrong. Not necessarily that it will go wrong, but just in case it does. So the assigning of an ASA is very, very effective for determining at-risk patients. So for example, automatically, if I hear that the patient has an ASA score of 3, then we start to adjust. We give lower doses of general anesthetics, and then we increase the amount of local anesthetics that we use. So what that does is it increases the safety margin that we have for these anesthetics. So we'll begin with local blocks. Local blocks are one of the things that I think are quite misutilized or underutilized, I should say, in the veterinary profession. They are mostly very easy to do. They are very quick and they cut the requirement for general anesthesia by up to half. So if you're using gas anesthetics, then our average gas anesthesia is about 1.5, 1.25% at 2 liters per hour of oxygen. And not only that it lessens the amount of anesthetic that you require, it also keeps your patient much more comfortable after the anesthesia. So for example, with regards to spaying, we use a splash block wherein we just spray bupivacaine in before we ligate the ovarian vessels and the uterine vessels. So what we do is we calculate at 2 to 3 milligram per kilogram of bupivacaine, and then we splash one on the left, one on the right, and one towards the body. So we divide the total dose into 3. And we spray that. We pause the surgery for about 30 seconds in order for the anesthetic to be absorbed. And it, in a study done in Colombia, because Colombia also has the same problems we do, they do not have access to opioids because, as we all know, they have a very big problem with illegal substances there. So they've found that up to 90% of spays that were just given a splash block of bupivacaine did not need rescue analgesia after. So they did not need additional analgesia after the procedure. And I found this to be true. Most of my spay cases are very comfortable for up to the next day when we give an oral NSAID. So local blocks, they provide preemptive and multimodal analgesia. So preemptive in the sense that you do not give the dog chance to feel pain, so that he's doing the breathing that we all know inside the surgery, where he's having problems because he's reacting to, or she is reacting to, the pain. What this does is keep your gas anesthesia at a very constant rate, or your injectable anesthesia at very minimal doses. It can be as simple as a infiltrative anesthesia, wherein you inject right after to keep that area of the incision comfortable for up to 24 hours. Again, we discussed it reduces the amount of general anesthetics. This is, I feel, one that is very often overlooked. Topical anesthesia. So you can get in the pharmacies a xylocaine preparation that is an ointment It's a form of lidocaine. It's also quick acting, and they use it a lot in dentists. It's the one that they put on your gums before they inject. For mucous membranes and open wounds and skin, you can use a little bit to help if you're going to need to do minor work. This is very effective. It's also a very good multimodal anesthetic before you inject lidocaine. So it helps desensitize the area where you're injecting the local anesthetic. Infiltration is the one I think most of us are familiar with, wherein you inject beside the incision that you're going to make or the wound or whatever, and you put a bleb and wait for it to take effect. This is one of the more common and easy to do um, local blocks, which is also underutilized in my opinion. It's a testicular block. It's very, very easy to do. So it's quite it quite nerve-wracking the first couple times you do it, because it is a sensitive area, especially for the male veterinarians in the in the audience. But it takes very little time, very little skill. It's very, very minimal cost, and it greatly reduces the general anesthesia requirements. No? So you have to surgically prep the testicles, and then they are oriented in their natural orientation, craniocaudal, um, and you look for the most caudal aspect of the testicle, and that is where you insert your needle. You aspirate, always aspirate. The testicles have very high pressure, so I recommend holding the aspirate for at least the count of 5 before injecting. And since you're holding the testicle, you should feel it as you're injecting the local anesthetic. You should feel it swell. And then the hallmark for knowing that this worked is there is no cremaster reaction when you ligate the vessel. So when you put your ties and then you pull it tight, usually if there's no um, anesthesia, the cremaster does this. So if your anesthetic worked, then they will not react when you pull your sutures tight. It takes less than a minute to do, and the dogs are and cats are very, very comfortable, even for hours after the surgery. This is one of the more daunting ones to do, so it can be quite nerve-wracking, but it's very, very beneficial for uh, digital masses. And for example, they pull their dew claw. That helps a lot. The nerves are they're right under the skin. So depending on which digit you want to anesthetize, you just go on top and below. So palmar, plantar, and dorsal. And then you can use local anesthetic as well. So it blocks the superficial branches of the radial median nerve and the ulnar nerve. They're very easy to do. This was a uh, tumor that we had to remove in one of the digits of one of the dogs. Dog did very well. The surgery went very quickly because no reaction to pain. This is, of course, before sterilization or disinfection. The intercostal nerve block is another local block that's scary to do, but very, very useful for thoracocentesis, let's say in warfarin poisoning or in a pleural effusion in a cat. So the nerves are found in caudal aspect of each rib. So you actually go down and hit the rib, and then you keep hitting the rib until you go off. And that's where you inject your local anesthetic. So you have to be a little bit careful because that's where the artery and vein are. So that's why you need to aspirate as well. Make sure you do not insert it into a blood vessel. Regional blocks. These are the ones that are uh, more everybody wants to do. Or sometimes you don't want to do them, especially in a dirty mouth. So the epidural is the most popular that everybody wants to learn. The dental is very important, especially for dogs that you should be doing dentals on. This is quite uh, dirty mouth is very common in dogs. It's a very quick and easy pain management technique. The effect is very drastic, especially in dogs who have very bad mouths and you have to remove teeth. Again, the comfort level is very, very big. Uh, it helps if you can get a hold of a skull from anatomy, and then you can visualize. So whenever we do this, especially when I'm teaching, I always have a skull model that we have in order to give the exact location. No, so the infraorbital regional block, its margin of the foramen is palpated just dorsal to the distal root of the third premolar. So there's a shelf that you look for. You go from the canine, go down, you'll hit a shelf, and that's where you insert your needle. No, in my opinion, this needle is too far inside. I only insert half of the needle, and then there are new studies wherein if you keep your finger over the injection site, it tends to block the entire upper maxilla or the right side. So you have to do both sides, left and right, if you're going to do anything painful on either side. For the mandible, the mental block, the it's the same thing. You aspirate. This is the correct needle placement. You don't want to go in because there are nerves in there, and if you go too far in, you're going to damage the nerves. This is what I look for, this triangle. You follow the canine down and there's a triangle of skin. And at that, the lower, if you're looking at it at the lower right side, that's where I insert the needle to go into that foramen. And then you inject and keep your finger over. If you remove your finger, lots of times the local anesthetic will come out. This is one that was not taught to me personally, and I find it very useful for fractures of the radius and ulna. It's relatively easy to do. As long as you can get an IV catheter in, you should be able to do this block. It's a regional anesthetic for lower extremities. So from the hock down and from the elbow down. Very useful in radioulnar fractures in small dogs, which I personally see a lot of. Uh, so it's a very rapid measure. You put a tourniquet on as you're putting on the blood vessel. The limb must be exsanguinated. So the way to do this is you wrap a pressure bandage around from the distal going up. So all the blood proceeds to go up, and there's very little blood inside the limb. And that's when you inject the local anesthesia. And that will last for up to 90 minutes, but no longer. So it has to be for short procedures. Now, my personal favorite and one that is very, very useful for anything that you have to do that's very painful from the umbilicus down. So, hip fractures, luxated femurs, broken femurs, broken tibia fibula. This is very, very useful. It's very easy to do. And another variant of it is very useful in blocked cats, which is a sacral epidural, which is at the base of the tail. And it has the same principles where you inject in between the vertebra at the base of the tail. And for unblocking cats, it's one of the most useful one. So epidural anesthetics, they abolish skeletal muscle tone, which is very important in reducing fractures of the hind limbs. They greatly reduce anesthetic requirements, and it's from the umbilicus down. So this diagram will more or less show what you need to look for. It's useful for all surgeries of the pelvis and hind limb. Uh, Cesarean section is very useful, and it's complete anesthesia to the caudal half of the body. So we have patients up to 8 hours after uh, with the epidural that they're comfortable even for very, very painful procedures like an amputation of the hind limb. They're quite very, they're quite comfortable. No? So the epidural is given between the L7 and S1. So you look for the lumbrosacral space, and you put a line in between the two iliac crests. So you'll be feeling for this vertebral process and the vertebral process of the S1. And then in between that is where you insert your needle. So you have to clip aseptically, and then you point both hind limbs towards the head. So you literally want the two hind limbs pointing towards the head. So what this does is, from a normal position wherein what I'm pointing at right there is the space where the epidural goes. That is before you point the legs to the head. And this is, of course, a little bit exaggerated, but this is after. So you open up that area and the spine continues down. This is a model that the spinal cord does not continue all the way down, but it should continue all the way down. And that is where you inject the epidural anesthetic. So what we use is either 23, 25, or 26 gauge spinal needle at 2.5 to 7.5 lengths. At this time, we are sterile, so we prepare it as a surgical prep, and we wear sterile gloves before we inject. And so this is the L7. I always look for the tops of the iliac crests, and then I feel for the top of that vertebral process of the L7 and vertebral process of the sacrum, and I go in between. Use your non-dominant hand to hold the space. So your non-dominant hand, I'm a lefty, so I use my right hand and I hold the iliac processes, and then I look for the vertebral process with my index finger. You insert the spinal needle, and as you insert the spinal needle, you'll be feeling a characteristic pop. It's like going through a membrane. If you can imagine going through a plastic, or if, since bubble tea is so popular, the moment that you insert the straw through the top of the bubble tea or the quickly, that's the same feeling but in the needle. And if you feel that pop, then you know you're inside the epidural space. That's the characteristic. That's the most important and most difficult thing to master. That's the scariest part. One of the tricks is there's a hanging drop technique where you put a drop of saline and you wait for it to go down when you're inside the epidural space. But for me, more consistent is having a syringe with 1 to 2 ml of saline, sterile saline, beside you. As you insert the needle, you have 1 to 2 ml of saline, and then you have an air bubble on top of the saline. What this is for is to make sure that you're inside the epidural space. And what it does is when you inject it, that air bubble should not compress. It should be smooth. So every time you push down, the liquid goes in, and every time you push down, the liquid goes in. Once you have that and it's smooth, then you're most likely inside the epidural space. So then we remove the saline and inject the either lidocaine, bupivacaine, or whatever you'd like to use. So a couple of quick tips. Always aspirate. Aspirate, aspirate, aspirate. No? Last thing you want is to hit a blood vessel and inject it intravenously. You will have bradycardia. If it's lidocaine, if it's morphine, you will have a lot of depression, intracardiac blood pressure as well. When you're giving an epidural, there's no resistance. As well as local anesthetics, there should not be resistance. And one thing I always check, especially when I'm teaching epidurals, a very good indicator that the epidural is working is there's loss of anal tone. So your anus will relax and the muscles will relax. So here are a couple of protocols I use. The safest anesthetic is the one you're most comfortable with, the one that you know and can predict what will happen. Okay? Just because I use this and I have access to certain medicines that not everybody can do does not mean you cannot. Everybody, I think, can get lidocaine. Everybody can get now bupivacaine, which is very easy to use. Get comfortable with your anesthetics. Start using them. Start practicing with local blocks. So we usually use 2% lidocaine at the dose of 2 to 3 milligram per kilogram. Bupivacaine is also much easier to get off. And we always use a multimodal approach. So there's we always use painkiller before. We use local during, and then we give an NSAID at extubation. So pre, during, and post, we have painkillers in order to keep the patients as comfortable as possible for as long as possible. There's a lot of controversy between tramadol and its use in dogs. In cats, it's very effective because they don't have the enzyme to use it. In dogs, there's a little bit more controversy. But I find that with an NSAID, it is quite effective. And since a lot of us do not have the access to opioids at a regular basis, these two are a very good combination that can be used. And we do use them regularly. It's just that if we need to increase, then sometimes we add gabapentin. Gabapentin is another painkiller that is coming into use. It's very useful in cats. And we've been using it to help mellow down very anxious dogs. It is a good long-term painkiller as well. So gabapentin has a very good future in countries wherein we have limited access to opioids. We induce using propofol, using it 5.5 to 8 mg per kg. But we do not give the full dose we use to effect. But we always have calculations in order to make sure that we have the proper dosing. And then we maintain with isoflurane at a concentration of 1.5 to 2.5%. 2.5% tends to be the more painful pyometras and cesareans, wherein the patient does not relax until the puppies are out or the uterus is out. So it takes a little bit more. That's why we give a little bit more anesthetics. I'll be happy to answer any questions. We're also looking for veterinarians if anybody is interested.
So, yeah, so thank you, Doc Gil. Okay, so anyone who have questions, you may use our chat box. Meron po bang questions? Napakaganda ng presentation ni Doc Niels.
Thank you.
Yeah.
Pwede in
Yes, Doc.
Tagalog, pwede sa
Yeah.
Bisaya, whichever. I'm I don't need to be if it's a language, please. I'm Filipino, so I don't look it, but
Ayan.
pwedeng
O baka nahiya sila, Doc.
madaming nahiya sana.
Okay, so we
Yun.
have a question here. So nag-direct message siya. So do you do total IV anesthesia?
We do, but for very quick procedures. We use propofol because the duration of anesthetic is very quick. So total IV, we usually use an initial dose to induce of propofol, and then we maintain with microdoses of propofol. But we always use local on top of it. A very good example would be unblocking of a cat. This is a quick procedure. Other times that we use it is, for example, cautery of small masses and tumors, wherein we're in and out in less than 5 minutes. But for longer procedures, we have the luxury of gas anesthesia, and we're very comfortable with it. So that's the one we use a lot of.
Okay, so another question, docs. Do you use paracetamol in dogs?
Paracetamol there's a new study coming out that it is effective in dogs. It's relatively new, but the margin of safety is limited again. So it's not something that you can recommend to your clients. It has to be through the veterinarian. There is a lot of promise in paracetamol for dogs. There are a lot of studies right now that are being conducted into it, and I think it's worth investigating. We are planning to use. We had a meeting the other week regarding this. We just not have had time to experiment,
Okay.
implement.
Yes. Another question. Nahiya siya, Doc, direct message lahat. So can lidocaine be given IV to reduce use of gas anesthesia, and how? So ulitin ko lang, Doc. So can lidocaine be given IV
Lidocaine, we don't recommend to
reduce use of gas
if
anesthesia?
lidocaine
and
is
how?
given. Yes. The only time we've used lidocaine is in conjunction with ketamine and diazepam. So it's a very good painkiller. It's a concoction that we use. But lidocaine alone cannot be given because it will reduce the heart rate. It causes bradycardia, and a quite severe bradycardia.
So okay na po ba sa ating nag-question? hindi ko na masabi. Si Doc. Doc, may isang question lang ako, although hindi about to sa dog at saka sa cats. Yeah. Oo. May nagtanong lang sa akin kasi hindi po talaga ako sa small animal practice. Sa government vet ako. So they want their rabbits spayed. Now, what do you think is the best anesthetic method you can use for rabbits?
Rabbits are very difficult to anesthetize. Ideally, you have alfaxalone, which is a propofol that you can give IM. It's alfaxalone. You can use ketamine, but rabbits are notorious for having very bad reactions to anesthetic. And your pre and post surgery are also very important, because pre-surgery, you want to keep them warm during the surgery, and then post-surgery, you want them awake as soon as possible and eating as soon as possible in order for their gut motility to move. So if their gut stops, the rabbit stops. So very, very tricky. Even with gas, I'm very, very hesitant I always tell my clients that rabbits are ×4 risk of anesthetic complications. Very, very tricky if you're not used to it. And injectable requires specific. So alfaxalone would be one of the safer ones, ketamine, but again, at your own risk.
Okay, so hindi ko na lang i-ano. Oh, another direct message. Where can I buy this bupivacaine? Tama ba yung ano ko? Sabi, saan daw siya makakabili, Doc, ng bupivacaine? No, bupivacaine.
It used to be na mas mahirap siya hanapin. Like we were only able to get it sa Bambang before, and it was much more expensive. But now our local supplier has it. Anybody that has lidocaine should have bupivacaine. So you can ask your suppliers there. I'm not familiar kung sino-sino mga suppliers dyan mismo. But anybody that has lidocaine should have bupivacaine.
Okay, so yun. So any more question? Meron pa po ba?
Yes,
I think, Doc, meron, Doc, sa inyo nag-direct message
more questions. Anyways, this is my email. If if my questions, you can just email me as well, and I'll be happy to help.
Doc, meron po si Rena Pepunsalan.
Hello, Doc. Medyo maingay. Nasa bahay kasi ako. Sorry po. Doc, itatanong ko lang kung meron ba available na yohimpin dito sa Philippines for silazine reversal?
No, at least I don't know if there is yohimbin. Although yohimbin I've seen has been in international conferences.
Kasi parang nagkaroon, Doc, ng time na spay and neuter kami sa isang shelter, and then nung pagkabigay sa kanya ng silazine, ayun, parang tawag doon, nag-heart attack na yung yung dog. Tapos hindi na rin siya na necropsy to check for heartworm, kasi gano'n naman, Doc, pag yung spay and neuter minsan wala nang mga blood test na ginagawa.
I would
ano ba ang pwedeng gawin pag halimbawa yung nag-overdose ba, or parang hindi maganda yung effect ay yung response nila sa silazine, bigla pong nag-cardiac arrest?
Well, cardiac arrest is already pag nag-arrest and nag-respiratory arrest.
Opo,
very there's only about 20% chance na mabuhay animal pag ganyan. So I would maybe look into ACE-PROM. ACE-PROM is a little bit more predictable in the sense na you can dilute it to a little bit lower concentration with sterile water, and then that's what we use for more aggressive na animals. And it's sometimes you can even give it intra-orally, so you spray it inside. There's a chill protocol, which is very useful if you look on clinician's brief. So if you know na medyo matapang ang dog, it's a very safe protocol. So it's gabapentin, melatonin, and then ACE-PROM.
Okay yun, Doc. Are you suggesting, Doc, na pwede yun gamitin for grooming? Kasi may mga times po na kailangan magpatulog ng dog dahil aggressive po yung like for example sa chow chow.
Chow chows are short snout, so you have to be very, very careful. Of all na pwedeng gamitin, this would be safe because there's no respiratory depression.
Opo, Doc. Compared to
Uh,
Silazine, Doc, na
and there's no cardiac.
delikado.
Yes. Yes.
Okay, Doc.
Yes.
Thank you so much po.
You're welcome.
Okay. So thank you, Ma'am Renape. Okay, anyone pa? Anyone who wants to ask question with docs?
I think there
Take
are a
this
couple of
opportunity
questions
na. Yes, Doc.
in the chat. Common anesthetic. Stop sharing my screen. Common anesthetic complications in dogs. Well, it depends on what anesthetics you use. Like, for example, I know that propofol, the most common complication that I see is apnea. In cats, they hold their breath, and in dogs, they don't breathe for up to 2 minutes. So automatically, that's something I'm aware of and I'm prepared for. So if, for example, I don't have any other option and only xylazine is there, so instead of giving the full dose at once, I would give maybe half the dose and see if it takes effect, or 1/3 the dose and see if it affects. And if it doesn't, then I would add another bit until I get the desired effect. Since I do not have the options of yohimbine or atepamezole, like one of the um, doctors here kindly pointed out, atepamezole can be used as well. It's the antidote to medetomidine, which also works, which is also not available here, unfortunately. So I would always try to, if I know I don't have any antidote, any reversal drugs, then I would work in stages, or I would combine things that I know are safe beforehand in order to be able to get the effect that I want. Now, the ASA scoring is also very important. So complications, um, let's say gas anesthesia will depress the blood pressure and will depress cardiac output. So if your dog has a cardiac problem, then I'll be looking more into opioids and certain opioids like buprenorphine that do not have a deep cardiac and blood pressure effect. So unfortunately, it really depends on what is available to you. And the whole reason why I concentrated on local blocks is so that the margin of safety increases. So if you're able to give the local blocks, if you're able to give all of these pre-meds and give several, like you're giving a painkiller like tramadol beforehand, and then you give a gabapentin, and then you give a melatonin, and it's an example. It's not what we use, but if you're able to add and stack um, medicines in order to increase your safety margin, then it mm, minimizes the chances of these complications. There's a follow-up question. If my opinion about xylazole cocktail, I have not used xylazine and zolethil in, I think, maybe 10 years. I would recommend that you look into propofol. Um, the side effects of propofol are much less. It used to be the propofol was very expensive because you had to use it once and then throw it away. There are much more stable propofols that are multi-dose, especially for veterinary use. They're much more stable. You can use them over time, and they are very quick anesthetics. So within 30 minutes, 30 seconds, the propofol can be out depending on how much you give. As for the xylazole, if you don't have anything else, then I would use it. But like I said, I would add other things on top of it. So I would not use only xylazine, zolethil alone. I would give a little bit of zole, just enough that the dog is asleep. I also recommend that you learn how to intubate, intubation is something that I think is very, very critical in the veterinary profession, and it really, really opens up emergency procedures. So if you need to breathe for the dog, CPR, it makes a lot of difference in the chances of reversing any of these extreme. Anesthesia is 99% boredom and 1% utter panic. And when you hit that 1%, you go from 0 to 300 in 2 seconds. So it's more about being prepared, being prepared for any eventuality. So use xylazole, but I would recommend you divide the dose of the Zolethil. Get the dog a little bit sleepy, and if I remember correctly, we used to use Ace Prom a little bit more than xylazine, and the effects were better. I honestly, don't quote me on that because I don't remember anymore about the xylazole. Pero look into Ace Prom if you can get Ace Prom. Dilute it if you can. Makes a big difference as well, because most of the preparations are very concentrated. I think that's about it.
So, yes, any more question? Baka meron pa pong question. Okay. 5,
Yes, please.
4, 3, 2, 1. Mukhang Doc, mukhang wala na. At napakaganda na actually ng inyong presentation. For us vets na hindi na masyadong nag-perform ng surgery, it's sort of a review na. Kasi lagi na lang dito. Hindi na namin alam yung mga gas anesthetics. Wala na yung kung ano lang natutunan namin noon sa surgeries, sa class namin sa surgery. Anyway, thank you very much, Doc Gills. Thank you for your time. I know you're so busy, but still you made an effort to be with us today. So, okay, picture, Doc Ayan. So before we close our tech talk, okay, photo ops muna daw.
Open video.
Okay, can you please open your video? Doc Ayan, can you please take the picture? Kasi hindi ako marunong.
Nawala ang puta. Visit.
Okay, Doc
Smile.
Ayan.
Smile muna, smile.
Ayan. Hello, Doc Ayan. Countdown. Ito talaga si Kuya Ayan, nahiya pa magsalita. You can please turn on your mic, Doc Ayan. Okay na, Doc Ayan? Pang ilan na ba yun?
Hindi ko maibalik. Naririnig ko, hindi ko maibalik.
Okay, pati po yung mic. Hello, Doc Tess. Doc Ayan, okay na po? Nakuna na ba lahat? Okay, naiiya yata si Doc Ayan Zialcita. Okay, finish. Done na. Okay, so thank you very much po. Okay, thank you very much for being here today sa 11th episode ng Tech Talk natin. Again, thank you very much, Doc Gills, in regards to Doc IB. Kasi siya yung speaker natin. Yes, thank you. Stay safe. Stay safe. Ingat
thank you very much, Doc.
Yes po. So see you next, I don't know when, next Tech Talk natin. 12th episode natin, I think it's about orientation, career orientation. Okay, so tayo ay ng mga future vets natin. So we're going to invite students from mga high school natin here in Puerto Princesa. Okay, so thank you very much po. And to those, yung mga Dalubhayop members, please wag muna po kayong mag-out. We will have a short meeting. So, ayan po. So, thank you. See you next.
Thank you.
In our next Tech Talk. Thank you.
Thank you, Doc.
Stay
Thank you,
safe
Doc.
po.
Thank you, Doc Guillermo.
Thank you, Doc. Thank you, Doc.
Thank you as well. Bye-bye.
Bye. So ito na lang pa yung Dalubhayop. Yung konti na lang natin.
1, 2, 3, 4, 5.
1, 2, 3. Oh, wala si Doc Patty
Teka.
kasi na-meeting siya. Oh, saan si Doc Jan? Nawala. Kanina nandito siya.
Nakikinig yun.
Ah, nakikinig.
Oh.
Oh, naka-duty
pasyente.
ata siya. Ay, may
May pasyente.
pasyente. Yes, Doc Ayan.
Teka lang.
Oo.
Wala na ba? 1, 2,
Wala
3,
na.
4, 5, 6, 7.
Nahanap ka.
Hello. Good
Hello,
Good
afternoon.
afternoon. Good afternoon.
Good afternoon po.
Naka-open pala ano ko.
Ano yung concern lang natin ngayong hapon ay yung sa for next week kasi nag-invite ako ng mga high school students. Pero actually wala pa namang nag-register pero hindi ko kasi alam kung anong dinidiscuss sa career orientation. Kaya hindi ko alam.
Tungkol sa career. Then naka-attend na ako dati. Parang
Opportunities
nasabi
sa
niya
bet.
kung ano yung
Hindi.
ginagawa ng profession niya.
Oo, naka-invite na ako
So,
ng
ganun na
speaker
alam ko
na dalawa, pero yung isa hindi pa confirmed, yung isa confirmed. Baka may gustong mag-volunteer.
I-volunteer natin si... I-volunteer natin si... Si Doc Jan, ayun no? Ayun, na-admit na si Doc Jan. Si Doc Jan, i-volunteer natin.
Hoy, baka manuno ka, turo ka ng turo, ah.
Pakagating ko nga eh.
Ikaw turo-turo dyan, ah. Ito, hindi na ako maka-attend halos dito kasi nagpaano ako ng pasyente.
Hoy,
Tapos
busy
ako
ang
pa
lola mo.
mag-i-speak. Oo.
Hindi, tatapat daw namin sa hindi mo duty.
Ay, nako, kahit na. Alam mo namang mahihayin ako, hindi nga ako makapagdasal.
Yung isa doon, poultry practitioner. Yung isa naman ay taga Rojas yun. Yung isa naman taga Cavite. Small animal practitioner.
Practitioner.
Oo.
Small animals.
Wait
Isa
lang,
sa ano,
ulit.
government service.
Yan, tama.
Si
Mas
Doc
maganda
Carla.
taga-LGU.
Naku, nagwala na.
Parang
Nawala na si
taga-LGU,
Doc.
si Doc
Nawala
Tess.
na si Doc Jan.
So si Doc Tess na lang.
No, no. Ay, si Doc Rodo.
No reaction si Doc Rod.
At least nakasmile siya.
Nakasmile
Parang
lang.
smile means yes.
Ay, si Doc, baka gusto niya. Si Doc Cresty sa military
Doc
service.
Resty, military service. Oo, kakaiba kasi.
I will let you know. Kailan ba yan?
Next
Next
week,
week
Doc.
daw.
Meeting.
Ay,
Next
hindi
week.
pala ako makaano yan. Naku, baka may Brooks Point kami nito. 22,
Kasi
no?
titingnan ko muna.
Kailan
ako,
to,
sige,
Doc
sige.
Ayan?
Martes.
Naku, may schedule kami Brooks Point. Isang
Ala.
linggo to. 22 to 25. 21, di pwede, may meeting kami yan.
In case lang, balikan po si Doc Carla ng 22. 25.
O, balikan nga kami 22.
Nandito sila ng
Kasi-
20 and 22.
Kasi ang antigen 24 hours. 22 to 25, wala.
In case lang.
So, si Doc, si Doc